The indications for performing focused emergency echo include anything that may involve the heart in an acute situation. Typically, these are things that may be symptoms of a pericardial effusion or other serious condition, including dyspnea, chest pain, hypotension, which is really a spectrum all the way through a code situation with pulseless electrical activity, tachycardia, syncope, and penetrating trauma. Of course, focused echo is often incorporated into other goal-directed examinations, such as the FAST exam or protocols that look at hypotension and include views of the abdomen and things like that. As you approach the exam, probably the first and most important thing is to get oriented. We'll talk about that. That just means understanding where you are relative to the patient, the anatomy of the heart, how the screen is oriented, and where the structures are relative to how they appear on the screen. In most examinations, if time permits, you should generally attempt to get 4 views of the heart. Would recommend that you try to obtain the parasternal long and short axes, the apical 4-chamber, and the subcostal 4-chamber and long axis view. The parasternal long is actually probably the most easily accessible and reproducible view, and it's one that I usually start with. The limitations there, if a patient is intubated or has a pulmonary problem such as COPD, the lungs may obscure that view, but generally that tends to be very reproducible and sometimes a lot easier in a situation such as where there is abdominal distension or discomfort and trauma, that sort of thing. If possible, try to get all 4 of these views, but again, as the situation will dictate, oftentimes you can't get all of the views, but you get as much as you can to get the information that you need. A few technical tips. As far as doing echo, it really does make a difference in terms of how the machine is set up to do echo, and there are differences between the machines and how well they handle echo. There are also things you ought to consider as far as the probe and the settings. If you ideally can get a phased array probe, this is a probe where the beam is electronically steered, and it usually appears to emanate from a point at the top of the screen. It's a sector image, and like most probes these days, it's typically broadband, usually about 2 to 5 megahertz. You can sometimes tweak the frequency a little bit. As you increase the frequency, you will improve the resolution but decrease the depth. If you decrease the frequency, you'll increase the depth but sacrifice resolution. A high frame rate is good for cardiac imaging because it's a moving image, so typically 20 to 30 frames per second at least. Tissue harmonic imaging is another process that the machines will have. It helps to highlight the borders between the endocardium and the fluid-filled ventricles. It can be very helpful when you're looking at the heart. Doppler is not required for most basic focused emergency echo, but may be helpful for some advanced techniques. We won't really be talking much about Doppler in this lecture. Orientation is particularly challenging in echo, and this is because of differing conventions between cardiology and general ultrasound. There is still some confusion and controversy within the emergency medicine community on how this is done. There are differences. These are discussed in an article that I published in 2008, and if you're interested, would suggest you review that. But most importantly, you should just understand where your probe indicator is and how that relates to the screen. If you pick a typical echo setting on a machine, the indicator will usually be on the opposite side of the screen, the right side of the screen, as compared to general imaging that you may do, such as in the FAST exam. And you can do it this way, you just should be aware of where the indicator is. One way to do this is just to put a small amount of gel on the side where you think the indicator is and look at which side of the screen this comes down on. In this lecture, we'll use a consistent orientation where we assume that the indicator corresponds to the left side of the screen as it is viewed, and oftentimes there's a little marker, in this case a little P, but oftentimes a logo on the side of the screen. Notice on the right side of this picture there's a P on the other side. So when we look at our primary views, in this lecture we'll try to stay consistent where the apex of the heart is towards the left of the screen and the left side of the heart is towards the left of the screen. So we have a subxiphoid on the lower left of the screen. This is very similar in orientation to the parasternal long axis in the general orientation, in that the apex again is towards the left of this patient or towards the right side of the screen. It's just a bit higher in the parasternal long axis, and you can see the aorta in the center of the heart. The apical forechamber, similarly the left side of the heart is on the right side of the screen as it is viewed, and you've just really slid the probe, the face of the probe out to the apex, and the heart will rotate on the screen when you do this. You may see a parasternal long axis view such as this, which is how the cardiologists do this. You can obtain this view in an ED setting by using what's called the fourth and long orientation. In other words, orienting the indicator towards the 4 o'clock position or the left hip in a general orientation to get parasternal long that corresponds to the cardiology orientation. Again, in this lecture, we're going to try to stay consistent with the indicator always to the same side and generally to the patient's right or patient's head, as in other ultrasound examinations. Anatomically, it's important to understand that the heart is an oblique structure that sits in the chest. It has a base and an apex. The base is towards the right shoulder, and this is where the atria and the valves are. The apex of the heart points really towards the point of maximal impulse, which is down, oriented towards the left hip. This gives the heart a long and a short axis. The long axis runs from the base to the apex, and the short axis will be perpendicular to this, and this will be important when we think about how the plane of the ultrasound is cutting through the heart and is displayed on the screen. You should also notice the pleural and pericardial reflections. We'll talk about that more in pathology, and the fact that the right ventricle is anterior. The aortic root is in the center of the heart as it emerges, but runs down the spine behind the heart as it descends. So windows to the heart are places where you're able to avoid air and bone in order to view the heart. There are 3 primary windows that we'll talk about. Again, probably the most easily reproducible window in most patients is the parasternal long axis. This is just to the left of the sternum, typically 3rd or 4th, maybe 5th intercostal space, again with the probe oriented towards the right shoulder in a general sonography orientation. The subcostal window utilizes the liver to look up into the chest, so it's slightly to the right below the costal margin, also known as subxiphoid, below the xiphoid process, but usually a little bit to the right and angling the plane of interrogation up towards the left shoulder is what you want to do to get that view. The apical window is just below the nipple. It will be under the breast in females and lateral. Both the parasternal and the apical views, but the apical in particular can be enhanced by having the patient roll onto their left side. This really brings the heart close to the chest wall and often will provide a much better view, particularly for the apical view. So we'll start with the parasternal long axis. Again, typically 4th intercostal space, maybe a little bit higher or lower depending on the patient. We will orient the probe so that the indicator is towards the patient's right shoulder, and the view should include the right ventricle anteriorly, the left atrium more deeply, the mitral valve and LV inflow, and we'll be looking at the left ventricle and long axis, and optimally we actually see the entire left ventricle out to the apex. In the center of the heart we'll see the aortic valve with the aortic root, the LV outflow tract. Here's a schematic showing how the heart appears in a cutaway view and how it should appear on a still image on the screen. You'll notice that With the indicator on the left side of the screen as it is viewed, the base of the heart will be on the left side of the screen, and the base includes the left atrium, the mitral valve, the aortic valve, and sometimes the tricuspid valve in this view, but often that's better seen in the subxiphoid view. So again, the apex of the heart is to the right side of the screen as it is viewed. The aortic valve is right in the center of the heart. The right ventricle is anterior, the left atrium is posterior, and you can see the mitral valve opening into the left ventricle. This will be easier to see in a moving image. So here's a clip showing a parasternal long axis view. You can see the right ventricle is the echo free space anteriorly. It's tough to see the right ventricular free wall because it's fairly thin, and that's normal. The left ventricle is the muscular chamber that's squeezing the blood, and right in the center of the heart you can see the aortic valve opening during systole for blood to flow through the aortic outflow tract, and you can see the aortic root fairly clearly on this view. At the bottom of the screen you see the left atrial chamber with the anterior and posterior leaflets of the mitral valve, in this case moving vigorously as it will in a heart that's functioning normally. And posteriorly towards the bottom of the screen, a little bit towards the right, is that circular structure, and that is the descending aorta. So the aortic root goes up out of the plane of the ultrasound and then descends along the spine, and you can see that sort of horseshoe sign or spine sign from the vertebral body that's shadowing, and the aorta is basically sitting right on there. And that will be important as we talk about pathology, both aortic pathology and pleural and pericardial effusion. So try to keep an eye on the descending aorta as well when you look at a parasternal long axis view. The long axis can easily be rotated into a short axis. In a general orientation, you would rotate the probe counterclockwise so that the indicator is towards the right hip. Cardiologists, when they use a reversed view, will have the indicator towards the left shoulder, and if you are trying to get a parasternal long axis view cardiology-wise to the left hip, you would still rotate it to the right hip. The short axis view is really good for getting a cutaway view through the ventricle and gives you a nice sense of how the overall chamber is contracting. In this case, we're watching a long axis to a short axis view where we can see a cutaway view of the papillary muscle. So it's the papillary muscle level. We won't be going into it in detail in this lecture, but you can also fan through the short axis from the apex to the base. The apex would be just beyond the papillary muscles, and then as you scan, as you tilt the probe back up towards the base, you get to the papillary muscle level, and then the mitral valve, which is also called the fish mouth, and then a little bit higher would be the aortic valve, which is a trileaflet valve and appears sort of like a Mercedes-Benz sign. To obtain the subxiphoid view, you should orient the probe again to the patient's right, place the probe just below the costal margin, usually a little bit to the right in order to use the liver as a window. And the key thing here is to place your hand over the top of the probe so that you can flatten the probe out and angle the plane up towards the left shoulder where the heart is. One good thing to do here is to identify the liver with the hepatic veins, and if you follow them, they should drain into the inferior vena cava, which then goes into the right atrium. Once you find the right atrium, the tricuspid valve should be apparent as it's opening into the right ventricle. The RV is next to the right-sided structure of the liver, and typically with a subxiphoid view, you should see the apex, often with the left atrium and mitral valve. The difference between this and the parasternal is that you typically will not see the aortic root, although you may in a patient such as those with COPD where the heart is very low. The subxiphoid view is an excellent view for pericardial fluid. It's probably the best view for that because the pericardial fluid tends to collect inferiorly, and so when you're looking from the bottom up, it will be very close to the probe. It's also good for overall function and can give you a nice view of all four chambers and the major valves in the heart. We'll talk about the right ventricle, but one thing to be aware of in this view is that because you can cut through the right ventricle in an oblique manner, it may make it appear larger than it actually would on some other views. So beware of overestimating the size of the right ventricle in this view. So here's a cutaway image of the cardiac anatomy showing how it would appear on a still image on the screen. So towards the top of the screen, the liver is being used as a window, and again, the right side of the heart is up right adjacent to the liver. The apex to the patient's left will again be towards the right side of the screen as it is viewed, and the left atrium, just as in the parasternal view, is towards the bottom of the screen as it's a very posterior structure. So here's a moving image. You can see the liver is being used as a window, and in fact the hepatic veins were followed into the IVC, then up into the right atrium, where you can then see the right atrium entering into the right ventricle via the tricuspid valve. On the right side of the screen as it is viewed, you can see the left ventricular cavity, with the left atrium again being the most deep structure towards the bottom of the screen, with the mitral valve opening between the left atrium and the left ventricle. When you're looking for pericardial fluid here, you would look at the interface between the right ventricular free wall and the liver, which is, again, the more inferior part of the heart and where you would generally find a pericardial effusion. While you're looking at the subxiphoid view, it's a good idea to rotate the probe so that the indicator is towards the head, and this will give you a view of the inferior vena cava as it drains into the heart. We'll talk about this in the second part of the lecture, but basically getting a view of the inferior vena cava can help you get a sense of volume status in the patient. The cardiologists also often do this view in a different orientation. They will also orient the probe towards the head, but the heart would be to the right side of the screen in a cardiology orientation for this. But like most ultrasound that we do, if we rotate the probe so that the indicator is towards the head, the heart, which is towards the head, is on the left side of the screen, and you can see that IVC draining into the right atrium. And here there's a fair amount of respiratory variation with IVC collapse, indicating that the patient is certainly not fluid overloaded in this case. The apical four-chamber may be one of the most challenging views to get. Again, it really can be helped if you get the patient to lie on their left side. When you can get it, though, it provides a really good overall view of the heart. You want to place the probe laterally at the apex, and that is probably the mistake I see most often with this view, is that it's too medial, and the view will have the septum running at an angle. Really, you want the septum running up and down. The indicators to the patient's right, and your view should include the left ventricle on the screen on your right with the mitral valve and left atrium, the RV on your left on the screen with the tricuspid valve and right atrium. Again, ideally you see the apex right at the point where the probe is making contact with the patient, so at the top of the screen, with the septum running vertically between the right ventricle and left ventricle. This is the best view for relating chamber size, overall LV to RV ratio. It's actually, I should say RV to LV ratio, which is normally about 0.5 or 0.6, and we'll talk about when the RV exceeds the LV, that greater than 1 is abnormal. This is a very good view for estimating overall function and taking a look at the atrial valves. And if you are going to do any Doppler, this would be the view you would typically do it in. Here's a cutaway view of cardiac anatomy in the apical view, showing the corresponding ultrasound image. in a still image. So again, the probe is nearest to the apex of the heart, just around the PMI, with the indicator to the patient's right shoulder. And as you look up into the heart, you'll see the left ventricle coming down the right side of the screen. Again, the septum should be running vertically between the left ventricle and right ventricle. The left atrium and right atrium are to the bottom of the screen as they are farther away. And on the left side of the screen, you can see the tricuspid valve between the right ventricle and the mitral valve on the right between the left atrium and left ventricle. You may be able to catch part of the aortic valve or aortic outflow. That's technically an apical 5-chamber or apical long axis, and we'll be focusing on the 4-chamber, but occasionally you may see that aortic valve in the center of the heart. So here's a moving image of an apical 4-chamber view. Again, the probe is placed at the apex with the septum running vertically. You can see the right ventricle, which is about half the size of the left ventricle. You can see the atria in the lower part of the screen with the mitral valve, again moving vigorously as the blood empties into the left ventricle and diastole. On the left side of the screen, you can see the tricuspid valve between the right atrium and right ventricle. There are many additional views, and really, as long as you understand your orientation and anatomy, you may be able to obtain some of these. I always talk about the low parasternal, high subxiphoid medial apical view, which is kind of a combination of the 3 views that sometimes is available in certain patients, and it's not really a classic view in terms of any of those 3 classic windows, but it can give you information, and if you're able to get a view of the heart, you should use it because it's a rare patient that has all 3 pristine views. We talked about the parasternal short axis again. You can go through 4 levels there, from the apical at the apex through the papillary, mitral, and aortic levels at the base, simply by fanning the plane of the probe from apex to base. An RV view of the parasternal long axis can be helpful. If you're in a parasternal long axis, it just involves tilting the tail of the probe slightly to the right and rotating so that you get a view of the right ventricle. Apical 2-chamber is orthogonal to the 4-chamber and includes the left ventricle and left atrium alone, but provides a different view of the left ventricular walls if you're looking for focal wall motion abnormalities. The apical 5-chamber includes the aortic outflow in the center. Apical long axis will also include the aortic outflow. Occasionally, you may be able to get an apical short axis, again, in patients where the heart has dropped very low, such as in COPD patients, where you can cut across the axis of the heart and get a donut view of the LV from a subcostal view. There is one other view, and I would like to actually mention this, as it can be very helpful if you have thoracic aortic pathology, although it can be a tough view to get and is not available in all patients, and that's the suprasternal notch view. This is obtained by placing the probe in the notch just above the sternum with the indicator to the patient's right shoulder. And in this case, what you want to do is typically find the carotid and follow it down to the aortic arch. And as it comes in, you'll see that arch, which then goes down. You can follow it sometimes to the aortic valve and then to the descending aorta. This actually shows an image with pathology where there is an actual aortic dissection, and you can see a flap moving along there. So you have to be careful because there are vascular structures such as the SVC coming across, and you don't want to mistake that for a dissection. Ultrasound is certainly not going to be sensitive for ruling out thoracic aortic dissection, but if you actually see a flap, it can be quite specific, and this is a view that may be helpful in a certain subset of patients. As far as the approach to the exam, as I've mentioned, the parasternal long axis tends to be the most reproducible view, and I would generally recommend that you start with that in a patient that's supine and you want to just get an initial view. If you're concerned about pericardial effusion, certainly a subxiphoid is best. and again, may be the only window in a patient with severe COPD or on a ventilator. If you're able to get the patient to turn on their left side, it can be very helpful with the parasternal long axis and apical forechamber. And if you can get all three views, that's ideal, but in many patients, you may only have one or two views, but really if you're able to get the information that you need, that may be adequate. So it's really important that you get to know your normal anatomy and orientation so you can appreciate pathology. So I'd recommend you do as many of these as you can, and not just pull it out as soon as somebody comes in with penetrating trauma or something really life-threatening. It's important to understand normal appearance of the heart so that you can appreciate pathology. As mentioned previously, all or part of the cardiac exam may be integrated into other symptom-based examinations, such as those in trauma, the FAST exam, dyspnea, which includes echo, in addition to pleural ultrasound and assessment of volume status, hypotension, which may incorporate the peritoneal spaces as well as the aorta and thoracic spaces, in addition to echo. So again, part of the echo exam may be integrated into these sort of multiple examinations of different body parts. The second part of this lecture, we'll talk about the 5 E's of emergency echo that we're going to look for in terms of pathology, effusion, ejection, equality, exit, and entrance. So hopefully you can join us for the second part where we'll go through how to identify what's abnormal. I want to thank SAM for giving me the opportunity to talk about echo. I appreciate your attention, and if you have any questions, please feel free to contact me via email at chris.moore@yale.edu. And hope that I really do believe echo can make a huge difference in how you care for emergency patients, and I hope that you learn to use it well. Thank you.